LOL שקט, נו. רגע, שנייה.
Okay, Yuval, you can start sharing your screen now.
No problem.
Yuval, if you don't mind, we'll just hold off on some more people joining in, and then we can start like once we have a few people in, right? So Manas will let you know when would be an appropriate time to start.
Okay, no problem.
Yeah.
Okay, Yuval, I think we can start now.
No problem.
Thank you.
Okay. So, hi everyone. My name is Yuval Schachte. I'm a first year at the first faculty of medicine of Charles University. And today I'm going to talk about the preclinical aspects of cardiovascular diseases. So just a small information about myself. I'm a military trained combat medic, senior EMT and ambulance driver in Magen David Adom, which is the Israelis emergency services organization. And I have a bachelor's degree in microbiology and from Bar Ilan University. So what are cardiovascular diseases? So cardiovascular diseases, or CVD, is a group of diseases that affect and involves the heart or the blood vessels. The underlying mechanisms of these diseases varies from disease to disease, and it depends, of course, on the type of disease and the patient's medical history. According to statistics from 2016, we had around 18 million people died from CVD. So a few classifications of the disease. I'm going to talk about three major classifications. The first one is coronary artery diseases, or CAD, which can be subclassified into angina and myocardial infarction, which is commonly known as a heart attack. The second type is peripheral vessels diseases, which is most commonly known as a stroke or DVT. And the last one is heart pathologies, which can be either heart failure or chronic heart failure, cardiomyopathy, and congenital heart diseases. So first of all, I'm going to talk about risk factors. The risk factors we can also divide into two classifications. The first classification is avoidable risk factors, which are smoking, physical inactivity, and excessive alcohol consumption. The second type is non-avoidable, which are age, genetics, sex, hypertension, diabetes mellitus, and hyperlipidemia. So first of all, we're going to talk about the avoidable risk factors, okay? So we have smoking tobacco, physical inactivity, and excessive alcohol consumption, okay? So let's dive in. We have the first risk factor, which is smoking and using tobacco. So this risk factor is considered to be the most avoidable risk factor, as people should not smoke, okay? It is very avoidable. And according to the World Health Organization, or WHO, smoking is estimated to cause about 10% of all CVD cases. Another encouraging statistic shows that people who quit smoking before the age of 30 have almost as low risk of death of CVD as a never smoker, which are people that never smoked or never engaged in smoking people. The second risk factor is physical inactivity, which means people who don't do physical activity, which are sports, actually. So this risk factor is considered to be very preventable, because we can always do physical activity. And according to the World Health Organization, a mere 5 times of 30 minutes of moderate activity per week, or 3 times of 20 minutes of vigorous activity per week, is considered to be physical active. So physical activity is very important to balance your energy throughout the body and weight control. Physical activity can also improve your endothelial function, which, as you know, the endothelial tissue is located within the blood vessels. And aside from contributing to weight loss and glycemic control, recent studies have shown that physical activity contributes to your lipid profile and normalizing it. The last avoidable risk factor is harmful or excessive alcohol consumption. And recent studies have shown that excessive alcohol consumption can cause an impairment in the endothelial tissue or blood vessels, causing and resulting in hypertension. And just small statistics, according to the National Institute of Alcohol Abuse and Alcoholism, excessive alcohol consumption is considered to be, in men, it's differentiated between men and women. And in men, consumption of more than 4 drinks on any day or more than 14 drinks per week. And for women, it is considered to be 3 drinks a day or more than 7 drinks per week. Okay? Now, let's dive in the non-avoidable risk factors, which are age, genetics, sex, hypertension, diabetes mellitus, and hyperlipidemia. Okay? Let's start with age. Age is considered to be the most prominent cause of cardiovascular diseases. As when we get older, it is there is a related condition of vascular aging, meaning that there is a change in the mechanical and structural properties of the vascular wall, leading to the loss of atrial elasticity and reduces the atrial compliance. And just for those of you who don't know, atrial compliance is the ability of the atrial wall to distend and increase the volume with increasing intervascular pressure. Okay. The second risk factor is genetics. Okay. So if someone's parents has suffered from some sort of cardiovascular diseases, their chances to suffer from CVD will increase 3-fold, okay? Meaning it will increase times 3. And most common cardiovascular diseases are inherited through non-Mendelian genetics. I'm not gonna talk about types of genetics, but yeah. And it is important to note that a lot of research is being conducted in order to understand the complete genetic components that takes place in CVD, because it's still fairly unknown all the genetics that are involved in CVD. Another non-avoidable risk factor is sex. Okay, so it is well established that men have a greater risk, 2 times fold, of developing heart diseases in comparison to premenopausal women. And there is an ongoing argument in the scientific community whether women that are postmenopausal will develop some sort of increase in developing cardiovascular diseases in comparison to men. Another aspect is women with diabetes is more likely to develop heart diseases when compared to diabetic men. Okay, and we're talking about either premenopausal or postmenopausal. It's insignificant in that aspect. Now, the final major risk factor is hypertension. High blood pressure is one of the leading risk factors to CVD. Okay. The usual aim of blood pressure is not to exceed 140/90 of your blood pressure. Above these values for a prolonged period of times, it is considered to be hypertension and will need to be treated accordingly via anti-hypertension medicine. Okay. The main issue with hypertension is that high blood pressure puts a strain on the myocardium, which can lead to an increased risk of cardiovascular diseases, myocardial infarction, and stroke eventually. Now, let's dive into classification of heart diseases. As I said before, we have three major classifications. The first one is coronary artery diseases, or CAD. The second one is peripheral vessels disease. And the third one is various heart pathologies, okay? Let's dive in. So we'll start with coronary artery diseases, and the symptoms are very common in those diseases, are very common, yeah. So the first one is, as we all know or heard, is chest pain or discomfort in our chestal area. The second symptom is shortness of breath, meaning that the patient will have hard time breathing. We can see sweating, nausea, vomiting, pallor, which means that the patient will be very, very pale, and pain could spread to the upper limbs, jaw, neck, shoulders, and even the back. And in women, there is a sign that usually we don't see in men, and it's signs that are similar to GERD. And for those of you who don't know, GERD is gastroesophageal reflux disease, meaning we have like some sort of a heartburn, okay? It's the acid reflux disease. So let's start. Coronary artery diseases, okay? We'll start with angina. Angina can be also subclassified into two very similar diseases. We have stable angina, which means that stable angina is a condition of a chest pain or discomfort that most often occurs with activity or emotional stress that passes over after a while. We're talking about maybe 20-30 minutes that it will be gone. Mostly angina is due to poor blood flow through the blood vessels of the heart, okay? And stable angina is considered to be less than 70% of blockage to the coronary vessels, okay? So we have some sort of blockage in the coronary vessels, and it's considered to be less than 70% blockage, meaning that we still have some sort of blood flow. The second type is unstable angina. Unstable angina is similar to the conditions and symptoms of stable angina, but the main difference is that it can occur in resting position, or when the patient is after light physical activity. Suddenly they can feel chest pain, which lasts for longer periods of time. And by that, we mean that if the patient is feeling chest pain for longer than 30 minutes, it is considered to be an unstable angina. Another major difference between stable and unstable angina is that, as we said, that stable angina is considered to be less than 70% of blockage. Unstable angina is considered to be equal or above 70% of blockage of the coronary vessels. Let's continue. Coronary vessels, artery disease, and myocardial infarction, which means that a heart attack, the most common coronary disease out there. So as I said, it's the most severe manifestation of coronary artery diseases. Chest pain is the main hallmark of all coronary artery diseases. However, it is considerably noticeable in patients that undergo MI, myocardial infarction. It's not always the case, as personally, I had patients that had undergone myocardial infarction and didn't feel any pain. Usually, we're talking in patients who have diabetes. Now, in order to diagnose myocardial infarction, we need to use a 12-lead ECG that we will show a case of STEMI, ST elevation myocardial infarction. And in patients that are experiencing non-STEMI and STEMI, will be diagnosed via blood test that will measure an elevation in the troponin levels, which is one of the proteins of the heart. Now let's talk about a case report that I personally had to treat. So I had a 65-year-old patient, an athletic with no previous medical history, no known family history of cardiac diseases. Suddenly, in the middle of the night, whilst he was sleeping, he suddenly woke up with severe chest pain that he never experienced before, and other symptoms included sweating, radiation of pain to the left arm and to the back. His vitals are: he had respiratory rate of 20 per minute. His heart rate was about 80 beats per minute. His oxygen levels were 99%, which means he's normal. His monitor showed he had a regular heart rhythm, and his blood pressure was a bit high, which is understandable when you consider that he's in pain. His ECG is this, okay? Very, very sickly heart, as you may and may not know. So what we can see in this ECG is that he has an anterior septal myocardial infarction, as we can see in leads V1, V2, and V3, with reciprocations in leads 2, 3, and AVF, and V5 and V6. This is V4, V5, and V6, okay? Which are the cordial leads, and these are the monitor, okay? So how did we treat him? First of all, we gave him anti-aggregates, meaning we gave him 300 milligrams of aspirin in chewing. Then we gave him heparin, which is an anticoagulant. We gave him 5,000 international units. And for the pain, we gave him nitrates, nitrolingual. And another thing for the pain, we gave him fentanyl, which is opioid for the pain. And what did the hospital diagnose? First of all, we did call the CCIU, and we ordered the coronary catheterization lab, where they found that he had 90% occlusion of his LAD. The LAD is one of the main arteries of the heart, of the coronary heart arteries, which is the left anterior descending artery. And they immediately, as we arrived at the hospital, they entered a stent, okay, to open the blockage. Now, let's continue with peripheral vessels disease, okay? And we're gonna talk about ischemic stroke. As you may or may not know, we have two types of major strokes, okay? We have ischemic stroke and hemorrhagic stroke. The ischemic stroke is what I'm gonna be focusing today. So, ischemic stroke is a condition as known as a cerebral infarction or brain ischemia, okay? It is a condition where there is an insufficient blood flow to the brain that is supposed to meet the required metabolic needs of the brain, okay? This leads to cerebral hypoxia, which leads to the death of brain tissue after 4, 5, 6 minutes, okay? Which is crucial in the aspect of time. We need to get to the hospital as soon as we see the first signs of symptoms of a stroke, and I will show you the signs in the next slide. Okay, so this is a very familiar and very well-known signs and symptoms of ischemic stroke, which is, you can see a facial downward, the face will decrease. You'll see that the arms are very weak, a very slurred speech, and the time since the symptoms have begun, and the time essence is very crucial, as we said, that after 4 to 6 minutes, brain cells start to die. Okay. Now, let's talk about deep vein thrombosis, which is DVT. Deep vein thrombosis is a condition that occurs when a blood clot or thrombus forming one or more of the deep veins in the body, most commonly in the lower limbs. You'll find them mostly in the lower limbs. The main symptoms of these conditions are pain in the limb and swelling of the limb. So basically, it's very common, but there are complications. And the complications are that they can cause blood clots to break and loose, okay? And think about it, that whenever we have a blood clot running from the legs up to the heart through the inferior vena cava, the blood clot will eventually reach the lungs, and then it will cause a severe condition which is called a pulmonary embolism. I won't talk about that, but it's essentially it blocks blood supply to the lungs, and then it will cause a very troubling it will have severe consequences on the patient, and it will have trouble breathing, and it can deteriorate very quickly. Moreover, in patients with varicose veins lack of collaterals, it can cause necrosis of the limb. And here's an example. Okay, so we can see here the necrotic leg. Let's continue. Let's continue with various heart pathologies. So we're going to talk about 3 major pathologies today. The first one is heart failure or chronic heart failure. The second one is cardiomyopathy. And the third one is congenital heart diseases. And in general, heart pathologies are chronic ailments that millions of people must endure on a daily basis. Okay. The first one is heart failure or chronic heart failure, okay, or CHF. So I'm just going to continue with that. CHF is considered to be a chronic syndrome with various signs of symptoms that originate from a problem in the heart that causes an impairment in pumping blood. For instance, it can be a result of previous myocardial infarction, renal or kidney failure, infections, excessive alcohol consumption. It's not a specific disease, but it's sort of a liability, and more diseases that can cause. The common signs are shortness of breath, fatigue, swelling of extremities, and chest pain. When I'm talking about swelling of extremities, try thinking about a pregnant woman with swelling in her legs. Okay, it's very similar in that aspect. As I said, mostly the cause of cardiac or kidney diseases. So what we will see in our patients, okay? First of all, we will see a distension of the jugular veins. You can see it here, okay? And then we can see in the next picture the swelling, which is actually a pitting edema. So this is when the examiner pressed on the swelling of the leg, and then this is after. You can see that it left a mark. Okay, so this is how it looks. Now let's continue to cardiomyopathy. These are groups of diseases that have a direct impact on the heart muscle. That we have several types of cardiomyopathy. We have hypertrophic or dilated or restrictive, or even Takotsubo cardiomyopathies. Takotsubo is most commonly known as the broken heart syndrome, okay? And we'll talk about it, in the next slides. The causes of cardiomyopathies vary in the type, but in general, it can have a genetic component and due to previous cardiac diseases or viral infections such as hepatitis C, for example, and more viruses. So as I said before, we have several types of cardiomyopathies. The first one is hypertrophic myopathy, cardiomyopathy, which means that there's an enlargement and thickens of the heart muscle, which basically means that the heart muscle grows in size, okay? The second type is dilated cardiomyopathy, and is a state where only the ventricles of the heart, not the entire heart, but only the ventricles of the heart grows in size, which makes them be weaker than usual. The third type is restrictive cardiomyopathy, which is a state where the ventricles of the heart stiffen and becomes less elastic than usual, okay? Now, let's talk about Takotsubo, which is commonly known as broken heart syndrome. The signs and symptoms of Takotsubo cardiomyopathy are rather similar to the symptoms of MI, okay? And in an ECG, it will mimic the characteristics of ST elevation MI and moderate rise in troponin blood tests. And the only way to distinguish between Takotsubo cardiomyopathy and STEMI and myocardial infarction is in the hospital, where you go, where they take the patient and take him to the cath lab or they do more tests, okay? Now, the final heart pathology that I'm going to talk about is congenital heart diseases, or CHD. And we have also here several types. The first type is, first of all, congenital heart diseases is a structural defect of the heart and major blood vessels that results in abnormal development of the cardiovascular diseases system during different embryonic stages of development. Meaning that the development of the cardiovascular system during the embryonic stages, okay, is very problematic. There's an abnormal development there, okay? The causes of CHD is mostly idiopathic, meaning that there is no specific reason for CHD, but there is a correlation between drugs, alcohol, or tobacco consumption during pregnancy, especially in the early stages of the pregnancy. The common types of are hypoplasia of CHD and septal defect, and these are what we can see. Hypoplasia is usually the underdevelopment of the right or left ventricles, like we can see here, and meaning that there is some sort of a septum defect, okay? And a septal defect is a result of blood flow, can result in blood flow between the two atria or two ventricles, as we can see in the picture. We can see either blood flow from the atria or the ventricles, as we can see in the right picture. So that's it for today. If you have any questions, I can answer.
The manifestations of stable and unstable angina are absolutely different, right? Or they're started by different, different things basically initiate.
Yeah, they're basically the same. But as I said, the main difference between the two is that and a stable angina and unstable angina is the duration of the chest pain and the amount and the percentage of blockage of the coronary arteries. So basically, the manifestation is very similar in how it feels.
Oh, thank you.
Any more questions?
So guys, I think if there are no more questions or if there are any questions saved for afterwards, Yuval is going to be here. But before people start signing out, we would like you to fill up the feedback form if possible. We will be sharing the QR code in like 20 seconds. So Yuval, if you could just wait on the side in case someone wants to ask questions later, so we can still like wait. Otherwise, we'd be really grateful if you guys could share if you guys could just fill in the feedback form for the event. Thank you.
Thank you. I'm still here.
Yuval, thank you so much. I'm just going to sign off, but thank you again. It was very, very interesting, very elaborate. Thank you so much again.
Thank you.
Yuval, if you could stop sharing your screen.
Yeah, for sure.
Yeah, thank you very much. Yeah, there we go, guys.